Alliance Evolutions Over the Course of Short-Term Dynamic Psychotherapy, a Case Study. By Luc Michel, Ueli Kramer, and Yves de Roten. Abstract. Background. Alliance evolutions, i.e. ruptures and resolutions over the course of psychotherapy, have been shown to be important descriptive features in different forms of psychotherapy, and in particular in psychodynamic psychotherapy. This case study of a client presenting elements of adjustment disorder undergoing short-term dynamic psychotherapy is drawn from a systematic naturalistic study and aims at illustrating, on a session-by-session level, the processes of alliance ruptures and resolutions by comparing both the client's and the therapist's perspectives. Method: 2 episodes of alliance evolution were more fully studied in relation to the evolution of transference, as well as the client's defensive functioning and core conflictual theme. These concepts were measured by means of valid, reliable observer-rater methods, based on session transcripts, the defense mechanisms rating scales, DMRS, for defensive functioning, and the core conflictual relationship theme, CCRT, for the conflicts. Alliance was measured after each session using the Helping Alliance questionnaire, HAq-II. Results. The results indicated that these episodes of alliance rupture and resolutions may be understood as key moments of the whole therapeutic process, reflecting the client's main relationship stakes. Illustrations are provided based on the client's in-session processes and related to the alliance development over the course of the entire therapy. Introduction. Therapeutic alliance has been shown to be related to psychotherapy outcome. Martin, Garsk, and Davis 2000. Several authors have suggested that alliance should not merely be measured at one point in time, but rather be understood as it changes over the course of the entire treatment, e.g. Castonguay, Constantino, and Gross-Holtforth, 2006. Empirically, recent studies have shown the relevance of alliance evolution as being related to outcome. De Roten, Fisher, Drapeau, Beretta, Kramer, Favre, and Despland, 2004. Kivligan and Shaughnessy, 2000. Kramer, De Roten, Beretta, Michel, and Despland, 2008. Kramer, De Roten, Beretta, Michel, and Despland, 2009. The aforementioned studies used formalizing procedures enabling the representation of either 1. General growth tendencies of alliance over the course of psychotherapy, or 2. Alliance patterns as groupings of clients presenting similar alliance evolution over the course of psychotherapy. Both methods are based on the principles of regression, focusing on the mean evolution and neglecting the session-by-session momentary fluctuations of alliance. As suggested by Safran and Muron, 2000, and shown by Stiles et al., 2004. The shape of alliance evolution may be characterized by local, session-by-session, V-shapes, generally interpreted as alliance ruptures and resolutions. The latter may be related to outcome. Alliance ruptures/resolutions and transference. According to Safran, 1993, the moment of alliance rupture is understood as a window into core themes of the client, page 13. It may be postulated that at the moment of alliance rupture, the clients and therapists enact the vicious circle which corresponds to the client's core conflictual relationship theme. Lubersky and Kritz-Christoph, 1990. For instance, an alliance rupture may be the result of a therapist intervention aiming at pushing a withdrawn client to self-disclosure. Safran, 1993. From the perspective of psychoanalytic theory, such interactional dynamics may be paralleled to the transference, countertransference dynamics in psychotherapy. Negative effect in the therapist is provoked by the enactment of the core conflictual relationship theme in the therapeutic relationship. Alliance ruptures, therefore, have an important diagnostic function in the reconstruction of the client's conflicts. Alliance resolution phases follow the moments of ruptures in positive therapeutic processes. Safran, 1993. They are characterized by what Alexander and French, 1946, have called the corrective emotional experience. The latter concept describes the therapeutic attitude facing the alliance rupture. Clinical illustrations of these processes may be found in De Roten, Michel, and Peter, 2007. The role of the client's psychodynamic characteristics. Defense mechanisms, reflecting the person's structural functioning, are key concepts in psychodynamic formulation and treatment. They are postulated to change over the course of dynamic psychotherapy, as shown by Perry, 2001. A client's defenses change throughout psychotherapy along the hierarchy of adaptiveness, from immature defenses to neurotic and mature defenses at the end of treatment. A recent study showed a medium effect size for change in the client's defensive functioning over the course of short-term dynamic psychotherapy. SDP. Kramer, Despland, Michel, Drapeau, and De Roten, 2010. Defensive functioning may also be related to the individual's intrapsychic conflicts. Lubersky and Kritz-Christoph, 1990. De Roten, Drapeau, Stigler, and Despland, 2004. The aim of the current single case study was to present a possible articulation between clinical material and research-informed assessment over time, in particular around the notion of evolution of the therapeutic alliance. This single case study was greatly inspired by the pragmatic paradigm, Fishman, 1999, which tends to bridge the gap between opposing movements, i.e., the positivistic approach versus the hermeneutic approach to the clinical phenomenon. The present single case study was based on the session-by-session monitoring of alliance as measured by a self-report questionnaire, in that it aimed at identifying alliance ruptures and resolutions. These episodes were related to the clinical evolution of the case, the underlying psychological meaning of the alliance ruptures and resolutions, as well as psychodynamic characteristics, i.e., defense mechanisms, the core conflictual relationship theme, and transference issues. Method. The client. Julia was a PhD student who had come to see us because she had been suffering from bouts of weeping and diffuse anxiety for several weeks, and this was stopping her from getting on with her work. She presented with a depressed way of thinking and various somatizations. This symptomatology appeared when Julia was coming to the end of her doctoral thesis and would have to start thinking about her professional career. In addition, she was not very happy about having two thesis supervisors, as she felt that there was a certain tension between them. One was ambitious and a good researcher, and the other gave priority to his family. She found this situation confusing, and it was paralyzing her. Julia was the youngest of 3 children. Both her parents went to university. Her parents married young, while still at university. Her childhood was marked by several house moves to different language zones, due to her father's university career. Her mother gave up her career to follow her husband. "My mother sacrificed her career for that of her husband," were her exact words. Julia remembers a particularly difficult moment in her early teenage years when the family moved. When she was 18, her parents separated. Julia chose to finish her schooling alone. She returned to her hometown to round off her studies and start on a thesis. The return was not easy in the beginning, and Julia went through a period of depression because she had trouble in readapting. An important element was that Julia had been in an intimate relationship for 5 years now and was beginning to see it as a long-term commitment. Her boyfriend had agreed to go abroad with her if her professional plans required such a move. The question of having children was a cause of distress. It's impossible to be a PhD student and pregnant. Julia was in a crisis when she consulted the psychotherapist at a crossroads, both professionally and existentially. The difficulty she had in making a choice seemed to relate to her parents' contrasting lifestyle. She realized that she was embarking on the same path as her father and felt a certain rivalry, yet also sought to please him by following in his footsteps. But how can she conciliate her career with her life as a woman reflecting the image of her mother and the sacrifices her mother had to make? Her internal conflictuality became a reality in her discomfort regarding her 2 thesis supervisors on whom she projects. We need to note that this client did not present any psychiatric diagnosis nor had clinically significant symptoms, as reported on SCL 90 at intake, discharge, and follow-up. The client explicitly agreed to the use of the data related to her psychotherapy for research. The therapist. The therapist was an expert in psychoanalytic psychotherapy and psychoanalysis. In this particular context, he offered specific short-term dynamic psychotherapy for university students. Gilly, Ron, 1997. Michel and Despland, 2006. In particular within the context of a naturalistic study focusing on psychodynamic psychotherapy of adjustment disorder. Kramer et al., 2010. The research team. The research team was composed of the therapist and 2 senior researchers in psychotherapy, co-authors. All members of the team have expertise in methodological issues. 2 are psychologists, PhD, and 1 is an MD. The use of the therapist as a member of the research team is described under procedure. Goals and context of treatment. The aim of the psychotherapy was to enable the client to become aware of and work through this crisis hypothesis. This would serve as the focus for the beginning of psychodynamic psychotherapy of a limited duration, 34 sessions, occurring once a week. The therapy took place within an institutional setting, psychiatric clinic, enabling the client to be reimbursed for the treatment according to federal law. Instruments. Therapeutic alliance. To monitor the therapeutic alliance, the patient and the therapist were asked to fill out the Helping Alliance questionnaire, HAq-II, developed by Lubersky, 1976, and Alexander and Lubersky, 1986, at the end of each therapy session. This inventory consists of 11 items rated on a 6-point Likert scale, ranging from -3, I strongly feel that it isn't true, to +3, I strongly feel that it is true. Only the mean score of all the items was used. The HAq-II has been shown to have a good reliability and validity, and it correlated with other well-validated instruments, 0.74 to CALPAS and 0.74 to WAI, according to Hatcher and Barnes, 1996. Internal consistency of the HAq in the sample from which the case was extracted range from Cronbach equals 0.79-0.89. Defense mechanisms. The Defense Mechanism Rating Scales, DMRS, was used to assess defense mechanisms. Perry, 1990. Perry et al., 2004. The DMRS is an observer-rated method that can be applied to the audio or video recording or the written transcription of various forms of interviews or of therapy sessions. Many studies have supported the validity and reliability of the method, e.g. Perry, 2001, Skodal and Perry, 1993. The defenses described in the DMRS are comparable to those listed and described in the DSM-IV, American Psychiatric Association, APA, 1994. The instrument includes a total of 30 defense mechanisms assigned to 7 hierarchical levels of defensive functioning: high adaptive, mature, obsessional, other neurotic, minor image distorting, disavowal, major image distorting, and action defenses. Each of these levels includes 3 to 8 individual defenses. As each level of defensive functioning is weighted according to its level of maturity, an overall defensive functioning score, ODF, can be computed to reflect the patient's overall defensive maturity. This overall score is used in this study. Transference. Transference was assessed by 2 methods, one well-validated, CCRT, and the other exploratory, Transference Dimensions Monitoring, TDM. We used both in order to provide 2 perspectives on the same concept and to explore the pre-validity of TDM. 1. The Core Conflictual Relationship Theme, CCRT, Lubersky and Christoph, 1990, is a content analytic method of the patient's relationship experience. The CCRT was Ally developed to reliably identify interpersonal relationship patterns described in narratives told during psychotherapy. These narratives are the basis for the CCRT method, which describes the relationship pattern in terms of 3 components. A. Wishes, needs, or intentions expressed by the subject, WS. B. Expected or actual responses of the object, ROs. And C. Responses of the self, RS, i.e. the emotional, behavioral, or symptomatic reactions of an individual to the other's response. The most prevalent of each of the 3 components is used to formulate the CCRT, which is the most pervasive relationship pattern across the self-other interactions. Negativity scores of RO and RS, in comparison with the W, may be computed. 2. The Transference Dimensions Monitoring, TDM, is a qualitative rating that we developed for this research. The instrument assessed 2 independent dimensions. 1. The nature of the transference, which refers to the maternal or paternal quality of the transference. And 2. The valence of the transference, which refers to the positive or negative valence of the transference. For the coding, the 2 orthogonal dimensions are placed on a target graph. After each session, the therapist placed a point in the target graph that best represents his perception of the 2 dimensions of the transference during the session. Procedure. Alliance and transference evolutions were depicted as graphs, figures 1 and 2, and submitted to all co-authors, including the therapist, in order to identify significant episodes over the course of the psychotherapy on these variables. All ratings, alliance, and transference were available to all co-authors at that time in order to be able to make cogent decisions for further analysis. Several consensus meetings were organized, interwoven with personal reflection. Thus, the consensus procedure was inspired by the Ward method in qualitative psychotherapy research, Schilk et al., 2009, yielding an iterative process towards consensus. Thus, the team met about 10 times during a 1-year period. The authors identified 2 significant episodes: 1. Sessions 4, 5, and 6, and 2. Sessions 21, 22, and 23. The first sessions of each significant moment may be described as the alliance rupture process, sessions 4 and 21, and at the subsequent 2 sessions, the alliance scores reached the local means, again, sessions 5 and 6, sessions 22 and 23. Thus, they may be called resolution sessions. These sessions were transcribed and analyzed using the DMRS and CCRT rating scales.